get genetic testing to see if they have the BRCA gene that would mean they face a higher likelihood of getting cancer.
It is kind of a moving target. The groups of people, like the red flag situations where we think genetic testing may be appropriate, keeps expanding. But here are some of the big ones. Women who are diagnosed with breast cancer premenopausally, usually, in their 20s, 30s, 40s especially, who have a family history of other premenopausal breast cancers. Women who have combined family histories of both breast and ovarian cancer. Any family where there's a history of male breast cancer. And I think one of the important things to know is not that it's exclusive at all, but the gene is way more common in what's called Ashkenazi Jewish women, so women of European descent. So nowadays, pretty much any Jewish woman diagnosed with actual breast cancer can and should be tested. And the number of Ashkenazi Jewish women who have the gene, which is shocking to some people, is actually 1 in 40. So a full 2% of the Ashkenazi Jewish population actually has the BRCA gene, whereas in the general population, it's more like 1 in 400. So it's 10 times more common. So as you can imagine, any Ashkenazi Jewish woman diagnosed with breast cancer is getting tested. There's even some initiatives afoot to test Ashkenazi Jewish women, even if they don't have breast cancer, with the idea being that if 1 in 40 are going to be found to have this gene, there may be options for those women for prevention that they would not have known about.
But what kind of tough choices do you have to make if you've tested positive for the gene but you don't have cancer?
In general, there are two main options over the course of time for those people, and it's very, very individually based. One option is what we call surveillance. Remember, we talked a little bit about MRIs, etc. This is a group where MRIs are critical, and in general, most of these women, BRCA-positive women, who have possibly an upwards of 80% chance of getting breast cancer in their lifetimes, would be screened very aggressively. Usually we do mammograms once a year, and we do MRIs once a year, and we split them up. So for example, a mammogram could be done every January, and an MRI could be done every July, so they're getting tested twice a year. We do physical exams on these people so that, God forbid, 2 months after a mammogram, they develop a lump, what's called an interval cancer. We ideally could pick that up early. Unfortunately, the only other option is really on the complete other end of the spectrum, which is what we call bilateral mastectomy or risk-reducing mastectomy. The only true way of preventing breast cancer in BRCA mutation carriers is by removing the tissue at risk. And so these are two diametrically opposed options, and obviously need to be weighed on a case-by-case basis. And, timing for one of the things we talk about in the book is ideal timing for one woman may be too early or too late for another. And it can have a lot to do with where women are at in their lives, etc., and how they feel about themselves and so forth.
Do you lean toward the let's watch carefully and monitor you direction as opposed to the double mastectomy direction?
No, I definitely don't. There are two genes, the BRCA1 and the BRCA2. In general, for those women who develop breast cancer with BRCA1, the tumors can be quite aggressive. Even the earliest, smallest cancers can be aggressive and life-threatening. So sometimes when a woman says to me, I'm going to just have mammograms and MRIs, and then when something develops, you'll pick it up early, right? And I turn around and say, the problem with these BRCA genes is that early detection is a goal. It's not a guarantee. And even the earliest cancer detected in a BRCA mutation carrier can be something that is A, associated with a risk of death, B, may need chemotherapy, and C, may be associated with all kinds of other downstream effects. So for the woman who is interested in the watchful waiting approach, these are all important considerations to make.
Since the BRCA gene is more likely to show up in women who are Ashkenazi Jews, do you always recommend to your patients who are Ashkenazi Jews that they get tested for the gene?
Many of them, yes. I think one of the most tricky things about the mutation is that the mutation can be handed down on either a mother or a father's side of the family. So imagine, if you will, that I'm an Ashkenazi Jew, and my father, and of course men don't get ovarian cancer, and very few get breast cancer, although some do, of course, and make believe my father had the gene, but it traveled silently in him. And make believe he only had one brother. And make believe the gene came through their father. You could see how I, quote unquote, have no family history of breast cancer, and then I develop breast cancer at age 35, and they test me and find out, lo and behold, I'm BRCA positive. How did that happen without any family history of breast or ovarian cancer? And it happened because I have a family with very few women on that side of my family. And so the gene can be very deceptive and very tricky and travel surreptitiously in families. So I do set the bar very, very low for testing in anyone where it may be traveling.
But that does lead to a lot of potential double mastectomies, probably in some women who never would have had cancer. So you're kind of opening the door to mental suffering and to very invasive surgery.
Sure. I mean, I think this is a very controversial area, but understand, with the BRCA gene, it is one situation. No one's advocating, I certainly am not doing double mastectomies on women without the gene. I have never really done that in any appreciable numbers preventatively. I mean, the cases are very, very few and far between. But what we're saying is that if you are found to be a BRCA mutation carrier, the likelihood that you will get breast cancer over your lifetime, and keep in mind, we never know with any individual person when that shoe is going to fall. And so the timing is difficult to determine as well. The risk of ovarian cancer is also incredibly important. Ovarian cancer is a disease that is usually caught much later than breast cancer. As I like to say, there is no really early detection of ovarian cancer. There's no mammogram for the ovaries. And so at the very least for these women, we can talk about ovarian removal after they're done with childbearing, and avoid that very lethal disease.
Because the BRCA gene also leaves you more likely to get ovarian cancer.
Correct.
For sure?
The risk of getting ovarian cancer with the BRCA gene is anywhere from 20 to 40% with the BRCA1,
I thought they were open this morning, and I had to go all
maybe
the way
up
to
to 20%
Yorktown.
with the
I
BRCA2,
can't wait to not drive so
and
far.
earlier onset with the BRCA1,
Yeah.
later onset with the BRCA2.
Thank you.
I imagine you've had to tell a lot of women that they have cancer.
Yes.
What does that take out of you to have to convey so many times such bad news?
Listen, I wish I could say it got easier as it goes along, but it certainly doesn't. And, and there's degrees of it, and it affects me every single time. But it is what we're trained to do. And I think for me personally, the only redeeming part is that that's followed very closely by, and here's what we're going to do to make you better. I think it would be much harder for me as a person to take care of a kind of cancer where there weren't so many amazing options for treatment and there wasn't as much room for optimism. And I think for me personally, that is what keeps me going.
If you don't mind my asking, do you worry about getting breast cancer yourself?
I do, of course, as a woman. I don't think I do obsessively. Personally, I have a complicated family history, but we don't have a huge breast cancer component in our family. But, the average woman's risk is 10% over her lifetime, and I don't think I think obsessively about it, but I do what I have to do to make sure I'm being checked. Exactly what I would recommend I do for myself what, I do for my patients exactly what I would do for myself.
Well, I want to thank you very much for talking with us.
Thank you so much for having me. I really enjoyed it, and I was so appreciative of the opportunity.
Dr. Elisa Port is the author of the New Generation Breast Cancer book. She's chief of breast surgery at Mount Sinai Medical Center in New York. After we take a short break, we'll listen back to an interview with Jack Larson, who played Jimmy Olsen on the 1950s TV series The Adventures of Superman. He died Sunday. This is Fresh Air.
WNYC receives support from the Mint Theater, an off-Broadway theater dedicated to producing lost and neglected plays, presenting The New Morality, a philosophical comedy of manners set on a houseboat on the Thames in 1911 through October 18th. More at minttheater.org.
Coming up at 3 on WNYC, John Hockenberry and The Takeaway on 93.9 FM and on AMA